Daniela Navarro. I am a family nurse practitioner here at or over at UCLA in Santa Monica. And my background is actually critical care, and I joined the radiation oncology department about 4 years ago. And approximately almost 2 years ago, I became their NP with our attending, Dr. Susan McCloskey, who has been my mentor in this whole process. So, yeah, I've been with the department in the family nurse practitioner role for about 2 years, and our specialty is breast cancer. So let me move on. And just real quick, obviously, there's no implicit bias in our presentation. There are no patients that are limited to consult based on their race, gender, sexual orientation, religion, political views. None of that is involved. There is no financial interest in this presentation, and it's strictly for educational purposes. So real quick, I just wanted to touch base on radiation fears. This is such a common thing that we see in our patient population. And this kind of comes off too from the nursing perspective. As I said, my background was critical care, and joining radiation oncology was a whole different role that I was not really aware of. So you definitely don't know what to expect, and you slowly learn into the field. So there's definitely, if you can only imagine what a patient feels when they don't even have that medical background. So there's a lot of radiation fears out there. There's a phobia of having the overexposure of radiation will cause additional cancers or other side effects. And they basically can go into the internet and see the extremes of radiation. And then just to real quick and give you an overview of what our department came up with. So around 2018, my attending, Dr. Susan McCloskey, and several other attendings and residents and the nursing staff conducted this survey. And they basically surveyed patients from, I believe it was like 2012 to 2016, patients who had breast radiation therapy. And they wanted to see what their actual perspective was on the initiative of the treatment, and what the actual outcome was and what the correlation was. And they published it actually with the American Cancer Society Journal. So this was the actual fears that they expressed. They had internal organ damage that they had the highest fears of. They were not aware of any other, if the actual lung would be exposed or the heart's exposure. So they were basically imagining the worst with radiation therapy. And then the second one was, the most common one, was also skin burning. They obviously saw the pictures on the internet, and they automatically imagined that would be the biggest side effect that they would get. The other ones are less common, but some of them felt that the fatigue would be overwhelming. They weren't able to carry out their normal routines, like they couldn't work, they couldn't go to school. And then one of the last one was like the minimal one was, let me see if I just move the screen over, was the actual appearances. They weren't really concerned about that, but most of it was the internal organ damage and the skin burning. And the main thing like coming out of that survey was, in reality, obviously radiation therapy, I'm sorry, I'm trying to minimize that screen there. Okay. It's a critical thing. It's a life-saving component of the treatment for these patients. Women and men today benefit the multitude of advanced treatment planning techniques intended to minimize these side effects. And then in our role here as a nurses, we play such a crucial part in educating our patients of what to expect, what to actually expect versus what's out there and what they can imagine going into this treatment. So this is my first Zoom poll question regarding patient radiation therapy fears. Aside of organ damage, what is the next most common fear in breast radiation therapy? Is it A, the cosmetic lift they're going to get, B, skin burning, C, glowing skin that they're going to get, or D, all the above?
Do folks see the results of the poll?
Yes.
Okay.
Yes. Yeah, so that's correct. Let me get into here. Sorry, I'm trying to go back to, there you go. Yes, B is the correct answer, skin burning. That is the second most common fear that the breast patients fear coming into. There is a cosmetic lift, and I'll get into that with later into the presentation, that they do get when on the site that's radiated, but it's not really a concern they have for the most part. It is a very small percentage. Glowing skin is not something they fear, and then all the above. Glowing skin is not like something that they're looking forward to, or their skin becomes better after radiation. Skin burning is the most common, or second most common fear that they have. So I just wanted to give you a quick overview of what our clinic goes through, and it might be very common throughout the world, and I'll go through each of these, but the most common or how it starts is with the diagnosis of the breast cancer. It can either be through the primary care, obviously, where they discover a lump or imaging, and the diagnosis is made, and then that's where the plan begins. So they either meet with surgery or medical oncology, like what the next steps are. Is there going to be surgery date? Are they going to be started on chemo? And all the calculations, all that has been started. And then they get to CT simulation, where our department comes in and they'll do the CT scan, and we begin our planning for the treatment. And the actual radiation treatment begins over the course of whatever is planned. And then the follow up care, which is a big part of my role in our department, where I do the follow-up care for our patients. This is just to give you an overview of the two most common breast cancer types that we have. And just to give you a little bit of review, that is the breast picture there. It's very, you can see the adipose tissue, you see the little alveoli in the breast where it holds the milk, and then you have the little ducts there attached to it, and then that's where the baby will feed from the nipple. And then on the right side, you see the normal duct, which is the duct from right here that you saw in the other image. That's normal duct where there's no cancer cells there. The one next to it is the ductal carcinoma in situ, the DCIS that we also label as, where you see the cancer is within the duct. It hasn't been invaded outside of the duct. And to the right of that is the invasive ductal cancer, where you can see the cancer has actually penetrated the duct wall and has invaded the surrounding tissues. So the types of breast surgery that are most common are, you have the lumpectomy and the mastectomy. The lumpectomy, you have here an overview of the pictures of what woman will have with DCIS or invasive breast cancer that require usually radiation therapy. In the picture A, the actual tumor, where the incision is made around the tumor, where the surgeon will remove the lump and any nearby tissue and also test those sites, and then will suture the wound. Then you have the mastectomy, which you see where there is just the mastectomy scar site there. There's no reconstruction done on that patient. Then you have the auto reconstruction, where they will remove part of the abdomen, sometimes inner thighs, and will replace that skin into the breast there, which is an autologous reconstruction. And then you have the implant, where they ultimately end up like with a mastectomy. And usually after surgery, they will have an expander put in to maintain the breast size. We'll have radiation treatment for them, and then we'll have the exchange about 6 months to a year after. But that is the common reconstruction for a mastectomy.
Hey, sorry to interrupt. We have gotten a few requests to speak a little bit more slowly.
Oh, sure. And so on this part, you have the whole breast and the partial breast treatments. On the left, the whole breast, where there's the radiation treatment type, will cover the whole breast. And that way you see the whole breast is involved in that radiation parameter. And then on the partial, you see the treatment is very localized to that partial side of the breast where that lumpectomy was. So that gives you an overview of the most common treatments we have, either covering the whole breast or a partial breast. And then the one on the right, so the regional lymph nodes, gives you an idea of what is involved in what lymph nodes are involved, like in a whole breast. You can see the parameter there around the lymph nodes of the intermammary lymph nodes, the axial lymph nodes. All those are involved in the whole breast, versus partial, when it's localized like that, a lot of these lymph nodes are not involved in the radiation treatment plan. Those are the two types. The treatment length, there are several, obviously you'll see several treatment plans, and they vary a lot from patient to patient. They vary on the diagnoses, the age, the type of cancer that's involved. So you'll see a variety, but these are just common. Give you an overview. This is the partial breast radiation after lumpectomy. So it lasts around 5 days. With this type of breast cancer, we really don't see much of a skin reaction. It's a lot of times it's a consecutive treatment where it's Monday through Friday, or it can be every other day. For some patients are attending if the patient is older or there's limitation with travel or something, or there are recurrence. Doctor, our attending is very flexible with that. So sometimes patients, our elderly patients, will only tolerate 2 days a week and they'll extend their treatment actually to a month when it's only 5 total days of treatment. And like I said, these patients really don't have much of a skin reaction with this type of treatment. Then there's the whole breast radiation after lumpectomy, like in that picture I showed you where they cover the whole breast. These can last 5 days. It can go up to 15, 16 days, or 25 days when it covers all those regional lymph nodes. And this also will vary patient to patient on the diagnoses. If they have strict in like DCIS, but in multiple sites of the breast, or invasive cancer of multiple sites, or they have aggressive cancer, such as like triple negative breast cancer or inflammatory breast cancer. They will have the more long-term breast radiation treatments, which leads to the post-mastectomy radiation. And that one is like the inflammatory breast cancer, where they will have a full course of 25 days plus a 5 to 8 day boost of treatment. And on that note, just real quick on the boost, when they have these full treatments, say 20, like 3, 4 weeks, our attending will sometimes add a boost at the end, and that can range from 5 to 8 days. The boost is localized for the most part along the lumpectomy or the mastectomy scar site, wherever the cancer had its highest gradient, where it was found the most. So our attending will give a little more longer, not necessarily higher dose. Sometimes it's most likely is lower, but we'll give them additional 5 to 8 doses at that site. So it ends up being like 30 to 33 treatments total. So those are the couple treatments that we give for the lengths. This is the CT simulation part. In our department, this is where obviously the patient has come in for consult and probably another return visit, but this is where we actually, in the nursing staff, meet our patients again to interact and have that introduction along with meeting our therapists too. So it's an important meeting where we can establish that baseline on this nurse's assessment and the role that we will have within the patient's treatment. So it's a very important day for us. So the nurse's role instruction, these are things that I'll touch base individually, but these are the common things that we are generally responsible for. The first one being the skin assessment, where the patients sees us first, usually the nursing staff, and then the nurses will have that first assessment, that first interaction will touch base on the fears these patients have. And sometimes things develop from the day of surgery till the day they get to us. The nurses will go over moisturizer. What are the common things that the patient might want to use and what we also advise to use? The most common are the side effects, what to expect, what actually to expect versus what they've already been informed on, say on the internet or friends. Any restrictions they have with activity, daily living. Is there a restriction to their workouts, their home or their school, work, anything like that we'll go over. Any diet restrictions that they fear. A lot of these patients are coming from chemotherapy and they've been on some sort of restriction. So they get to us and they assume that they're going to be on full restrictions as well. So it's very important to touch base on that. And the expectations, are they expecting, some of them expect that they're going to have a full reaction to their skin, and some of them don't know. So it's a good thing to touch base. And then the follow-up care. And again, this is where my role steps in. And we want them to know that even though they'll be done with treatment either 5 days or a month or so, we will always be there also for them. We'll follow up with them a couple weeks after treatment, a couple months after, and so on. We have patients that we follow up 10 years out after, and some people will only do a couple months. So it varies, but all these steps are very important, and I'll go in individually in each one to give you a couple more examples. So the skin assessment part of the nurse's role, these are a couple things that sometimes our nurses will come across that a patient is left with or walks in and they were not aware of, or things develop. So like drains, there's a common JP drain that some of these patients have after surgery. And sometimes our attending knows and they're expected, and sometimes they think that they've been removed, but they come up with them. So it varies. But the drains, so a JP drain may be seen dangling from the mastectomy scar site. Sometimes there's cause, sometimes there's packing. Sometimes there's a seroma that develops or a hematoma after surgery. There's like just a pocket of fluid that can build up at that site. And that can happen honestly right after surgery. It can happen during treatment. It can happen after treatment. And those can get infected. So I'll go over that too in a little bit later. But those are sometimes things that will stand out when you see a patient when they initially come on their CT simulation day. Then there's infection, like I was saying in a seroma, sometimes the breast, you feel they're going to be ready for CT simulation that day, and in reality, they've developed an infection. So the breast might be inflamed, red, tender, patient might not be feeling well. So that's a good thing to know what to look for. And then sutures. Sometimes sutures are left behind, which is normal. They'll just fall off on their own, but sometimes they're very bothersome patient, or they have a long piece dangling that we can help with and remove, but for the most part they are left alone. But these are common things that we see when patients come in after surgery. Usually the surgery is about 4 to 6 weeks before they get to us, so some of these things are present. Some of them we can either move on and continue, like a seroma, we would continue with the scan, but we would monitor it on the size. Obviously, if there's an infection and the breast is swollen, then obviously we would not continue because of the size varying from that day to the actual day of treatment. So these are very important just to be aware of. Obviously, the attending would take the role and decide what to do, but it's something that that the nurse can be aware of too, and reassure the patient that they would be taken care of adequately in that role. So moisturizers, there's a couple ones that I have here, and they vary this across the world on different types that clinic will advise to use. We are on calendula, and that is something that we are attending is favors because there's been good studies on it showing it has had good moisturizing and aftermath effect on helping like the discomfort, like the burning and feeling and healing of the skin. And it's a homeopathic cream that has good data on. Make sure that's the calendula. These other ones, like the Biafine, Aquaphor, Cetaphil, and I'm sorry, I went too far. Like Biafine and Mioderm, they're a little more pricier. They're not, like the Mioderm has actually calendula in it, but some patients do their own studies and they want to use it. The Biafine is very pricey. It's not something that we recommend, but we're open for the patient to use. Aquaphor is a very thick and got Vaseline texture where patients love to use because it moisturizes the skin. And a lot of times in our patients that do desquamate and have that dry effect after the dry desquamation, Aquaphor has been very beneficial. And Cetaphil, obviously, we're okay with that, or CeraVe, anything that doesn't have too much alcohol in it or perfume, we're open for the patient to use. I know aloe vera is something that has been studied recently and shows that it actually has a drying effect on the skin. So that's something that we are open to advise patients to most likely stick to the calendula and the aquaphor. We have calendula in our clinics, so we can start them off, especially at the beginning of their treatment with that. But some patients are adamant to do aquaphor or Cetaphil, and that's okay too. But for the most part, we ask them to show us their lotions at first, so we make sure there's no additives to it. There's other supportive pads we use too. There's the Mepitel, which is that top one up there, the Polymem, and the Mepilex. The Mepitel is more of, it's like a gel mesh, I would say, and it's a silicone gel. And then the patients would apply it to the chest wall. I know the study was done on a mastectomy, and they had really outcomes, the good outcomes. The skin was actually very preserved and it keeps the skin moisturized. So it's great for those patients that are getting 25 plus treatments, and the Mepitel can stay in place without movement. So it works well. We've also used it on patients based on their personal strong preference, like on larger breasts. And that can be a little difficult because you end up being like a daily seamstress because a lot of it is falling off and every day you need to adjust it. The nice
Yeah.
thing about the nice thing about it is that it has pores, so you can apply cream on top of it. Say the patient does have some desquamation or they're itchy, you can apply like a cortisone, or if they are desquamated, you can do Silvadene. So in that aspect, it can work well. The pink pad and the Mepitel below it, they're good for friction. If the patient, especially for larger breasts, or patients who are very active and they have the like the chafing effect from the underarm or the breast fold, these are great supportive measures where it prevents that friction, the skin to skin contact. So we definitely give these out at all the times as a preventative measure. There's some patients that we know are going to have that skin breakdown along the way who are larger breasts or who on purpose are attending will treat the skin at a higher dose, those inflammatory breast cancers where they will definitely have a higher dose to the skin with like a bolus. So those are pads that we definitely give out to all our patients. So the nurse's role, again, this is a common radiation treatment side effect that we want to establish. Like I said previously, there's patients that will have that fear that they're going to have the severe desquamation. And it's good to inform them, like, what's the actual expectation? The picture in the middle is what we commonly see actually with most of our breasts. They'll have a faint redness developing. You'll see the outline to the breast, and it can be a little tender. The fold is probably a little red too in that picture. The pictures on the right, I wanted to give you an idea of why I put it up. You see the exposure there, that's an actual sunburn for a patient, and that's the area that most of us do have a lot of sun exposure, and then it ends up being the area that we see with patients have the most common rash in that parasternal site. And just to give you an idea, this is why of all that sun exposure we've had since our childhood, we can have that reaction, that parasternal site. And that picture below, I wanted to show you, obviously it's not a breast, but you can see that dermatitis effect, that rash is what you would see at that parasternal site. But that kind of gives you an idea of what the most common side effects are post to radiation. This is the grading scale that a lot of us will use. It's the CTCAE scale that gives you an idea of the grading for our radiation side effects. So the most common that we see would be 1 and 2. There's a little bit of redness, and sometimes there's some dry skin that develop in that grade 1. There's grade 2, where there's moderate to brisker erythema developing. Sometimes it's patchy. Some parts are a little moist, where there might be some skin peeling. And that's common, like I was saying, in the breast fold or underarm, where those pads, for instance, would be a good supportive measure. Then 3 and 4 are rare. The third is the highest that we've seen, where it gets really desquamated. The skin is broken. There's sometimes a wet or moisture, and there's sometimes bleeding at that site from the skin sloughing off. Sometimes the pads will remove part of the skin, and you see a little bit of bleeding. And obviously, along with that comes with pain too for the patient. And then obviously the life-threatening, which is really not really seen in our department, where you can see the skin necrosis falling off, or they get like deeper ulceration to the dermis and spontaneous bleeding. But a lot of times for these are skin grafted, but honestly, in our department, we have not seen that. So I would say 1 and 2 are the most common criteria that we see in our department.
Well, one day. Oh,
Gives
okay.
you a little bit of what the grades look like. You can see the redness on that grade. The grade 1, grade 2 has a little bit of starting to get a little of that moisture, that desquamation, a little bit more skin irritation. Here you definitely see more of the moisture. You can see bleeding occur. And the bottom one, you see a little the skin. A lot of these are the breast fold, where the underarm, which we see as well. You can see more of the skin breakdown there too. And then 4 are the extremes that we rarely see, where you'll need actual skin graft from the severe loss of that dermis level. So these are the scale pictures. And on that note, I also wanted to touch base on the actual radiation dermatitis versus infection. On that picture on the left, where you see the outline of where the radiation has been treated or the skin that's been treated, which is common. That's the faint redness that I was talking about. But the one on the right, where you see the redness kind of localized in that central breast, that's something that to be aware of and not to be confused. That's I know that's part of radiation. They're very close in appearance, but the one on the right you can see is more of an infection that's occurring, and a lot of times those are occurred by a pre-existing seroma or hematoma that has developed from surgery. And again, that can happen right after surgery. It can happen in the middle of our treatment. It can happen after. It's good to be aware that and not just push it aside and say this is all cause of radiation, dermatitis, or erythema, but this is more of an infection where in our role we would get them started on oral antibiotics and follow up with them after the course and see. And we've done that in our department. We've done it. And honestly, like a couple months later, sometimes it comes back. Sometimes these aromas by our breast surgeons will have to be drained, and it's just a pocket of fluid that can fill up aftermath. So it's a gray area, because do you drain it and expose the skin again to a possible infection for a later time, or do you just treat it with antibiotics and monitor it? And it also depends how the patient is responding. The picture for the radiation erythema, usually they're complaining of kind of general tenderness and maybe a little burning, but the one with the infection on the right lower corner, it's probably hot. They may have a fever, and it's probably much more tender than the common overall tenderness of that whole chest wall. And this might be a little more localized. So that's something to distinguish. And again, just let the providers know of any concerns there.
There's a few questions that I wanted to bring up at this point. So the first question was, when should moisturizer be used? From day one or whenever side effects start to develop?
That's a good question. I'm sorry I didn't mention it earlier. We started on day one of treatment in our CT simulation day. When we sit with them and go over all the instructions, we ask them to begin on day one. And we show them all the location sites. If it's a whole breast, including all the lymph nodes, the subclavial, iclav, sorry, lymph nodes, we'll have them covering all the way to the back, the whole rectangle, the underarm. So we'll go over those sites. But on day one is the initiative on the lotion. And then once they complete treatment, we'll have them continue for another 2 weeks, because that's around the time we have them come back to our department and we'll do skincare. And I'll talk about that in a little bit too.
I have two more questions. So the next question was, can whole breast radiation treatment be done on a breast that is draining too much?
That is draining too much.
If there's a breast with a wound that is draining, can you start whole breast radiation, or is there a reason to delay treatment until the wound is closed?
Yeah, sometimes they'll have those JP drains. So yeah, on that note, a lot of times our attending will touch base with our surgeon, and usually they will delay it just because on the size of the breast fluctuating too. And they want to make sure, just because they'll do the scan and they take an image of the breast, and that's the size that our doctor will plan out the treatment. And say they come back a week later to begin treatment, that size of the breast might have changed. In that case, our CT scan and our plan will not match what the patient looks like on that first day of treatment. So for the most part, yes, they would delay for that.
Yes, and then I would say from a radiation oncologist standpoint, if there is an open wound that is draining, then we would want that to be well healed, since once we start radiation, that could worsen the wound and prevent healing. And the third question was, how long should a patient wait to start radiation after a mastectomy?
For the most part, they'll definitely wait about a month to 6 weeks or so after surgery. Like you said, there might be drainage, the healing of the wound might take a little longer. So it will fluctuate. And then sometimes these patients are in chemo treatment after surgery. I would say in general, like up to 6 weeks, we would wait to see. Okay, so back to the nurse's role. The uncommon side effects that they can expect. So they'll, like I said, Google is a very big part of this. They'll get pictures and see the extremes on radiation or radiation effect to the breast. So, on that note, can we predict which patients are at higher risk of acute toxicity from breast radiation? And yes, we can. These are very common with patients who have like whole breast versus partial breast. If you remember from that picture where you do the radiation course to the entire breast or just the localized to that partial breast. It's common to see in patients who are much larger breast size. For some of these patients that have large breasts, our attending will do treatment versus them laying on their back. When they do the scan, they'll lay prone. That way, only the breast is being irradiated to avoid possible extreme toxicity to the skin. So that's another option that our attending will take in consideration and choose to do that. More skin folds if the patient has more at the axilla or they're a little bit larger, that those areas that have more skin to skin contact and friction would have a little bit of more reaction from radiation. Patients requiring the use of bolus. And this is a gel, like silicone, that they would put over the patients during treatment. And with this, the radiation will give more treatment to the dermal level. So the patient is actually expected to have that brisk erythema reaction, which is expected. And in this case, along the way, our attending will definitely instruct me and our nurses too what patients will be expecting this. So there's a bolus effect that is placed on the chest wall or the breast, and the patients will develop a higher brisk reaction from radiation. So we are constantly monitoring them along the way. We do our weekly visits, but on patients like this, where we are going to expect the brisk reaction, we will see them we'll watch them a little closer. And then at times when it gets really brisk and red or desquamated, then the attending will make the decision to remove the bolus, give the patient a couple breaks. They'll continue with radiation, but the radiation will be focused anymore at superficial where the skin is actually targeted, and it'll still penetrate the breast tissue beneath, but that way the breast skin won't be as brisk. Poor hygiene. If patients are we have some patients that don't want to look at their breast, they don't want to touch it. They'll have our nurses to apply the cream, or they're afraid to even take a shower, touch it on the underarm. And that sometimes that will develop bacteria and increase layers of the lotion. So that can also cause areas of a little more toxicity to the skin. And then it goes into poor compliance with skincare. If they're not adequately cleaning, bathing, maintaining the lotion. Sometimes patients don't want to apply anything and they end up developing really dry skin, which also is bothersome and not recommended in our department to prevent or to encourage the moisturizing of the skin and prevent any other breakdown.
Hey, Danielle, we have a few more questions. Maybe you can take them before the poll. One question is, can one develop radiation-induced dermatitis weeks after completion of radiation?
Yes, that's a great question. That's one of our reasons too. We have our patients return at around 2 weeks after radiation is completed. Some patients will be fine throughout treatment, and this is commonly seen in our partial breast or shorter course patient treatment, where they'll be fine 5, 10 treatments in. They have no sensation, no fatigue, nothing. And then after the math, they will have an increase of the redness or the fatigue in that week when they're no longer with us, versus the patients that have the month treatment. You see a lot of the side effects around halfway, just because with radiation things our symptoms are gradual, they're predictable, they're slowly will stack on. And by week 3, 4, that's when it's peaking effect, and we can see the skin really change or them feeling tired. But in those short courses, when they get to that 5, they're done, and in 2 weeks they're at home, we don't see the aftermath. And yes, so we definitely can see the aftermath occur in those weeks after radiation. And it's just part of the cell regeneration that's happening after the fatigue comes on, just the same reason we've the radiation has killed good and bad cells in its path during those 5 days of treatment. And then the weeks after, our body's slowly regenerating to get back to their baseline, and they'll have the effects come after.
Next question is if reconstructed breasts are at higher risk of acute toxicities.
It depends. I would say some yes, because they're most of the time, if they had a mastectomy or a larger lumpectomy, they will have more of an aggressive cancer where our radiation oncologists will calculate higher doses of treatment. And doctor, you can also add to that, but I would say they do have a little bit of a more reaction than like a partial breast where they had really low grade DCIS diagnosis, where it was just a localized lumpectomy and partial radiation treatment versus the whole mastectomy site, where they do have a higher gradient of radiation or prescribed to them. And they tend to have a little bit of a brisker reaction, but it really does vary on the diagnoses, the surgery, the patient's pre-existing issues. Some patients, like I said, will have like the radiation tends to be a little more prominent in darker skin, so sometimes that will take effect on that too. Or they have other pre-existing issues. Some of them will have like lupus or any autoimmune disorder that can heighten that reaction for patients. But yeah, with mastectomy, I would say it's more brisker than maybe like treatment.
Yeah, I can add to that too. So with reconstructed breasts, I would say, like what Daniela said, oftentimes they're not the ones getting partial breast. So they might be getting more radiation, and that could lead to more acute side effects. Also, if by reconstruction, if they are talking about a reduction or anything that involves larger scars in the area that's getting radiation, that can increase the risk of scars breaking down and things like that. Another question we had was, how many fractions of radiation is one with breast cancer expected to get? And please clarify if I am misunderstanding this, but I think maybe the question one is how many fractions in general, but also maybe after how many fractions can you start to expect to see acute side effects?
Yes, like I said, it's a very gradual effect. So usually those first 5 fractions, we don't see much like that. First week on treatment, we barely see some pinkening maybe. And then usually week 2, week 3, if they're on that longer course treatment, if they're having 15 to 20 treatments, usually week 2, we'll start seeing a little more pinkening and redness develop. A lot of times it's to that peristernal site that I said have a lot of sun. We've had a lot of sun exposure. That area can get a little red or rashy, but maybe like week 2. And that's why like for those partial breast treatments, after those 5 treatments have been completed and they go home after, we don't see them come back, we don't see this reaction. So I would say probably week 2, week 3 is where we start really noticing any outline developing or symptoms that the patient will develop. But on that note, we have seen some patients have a little bit of brisker. The really fair patients can have a little bit of a brisker reaction that first week, and usually the body will stabilize after.
Okay, we have a few more questions. Maybe we'll ask a few and then start the poll. And while we're polling, maybe we can ask a few more. Another one is, can anyone explain what radiation recall is?
The radiation recall. No. Do you have a little insight on that, doctor?
Recall that can happen, for instance, if someone gets radiation and then they go on to get chemotherapy, sometimes they can have an increased reaction in the area of the radiation field. So sometimes chemotherapy or immunotherapy, any kind of drug therapy, can cause a rash, but when you see it come back in a very distinct shape in the area that the patient got radiation, that would be an example of radiation recall.
I've had that. Sorry, yeah. It's like patients who are on immunotherapy. I think it's Kadcyla, one of those. We've had to pause their course during treatment because they were just having that brisk reaction during radiation. So
we've also seen it in patients who get adriamycin. And typically, when people are getting chemo, it's sequenced before the radiation because of that fact. But that's a common chemotherapy agent that's associated with radiation recall. And you would treat them just like you would treat radiation dermatitis. It usually will go away on its own.
Yep. And so usually it happens someone has received radiation, usually. Okay, and then maybe we'll ask one more question before we launch the poll and then we can follow up. So it says, can you speak to what follow-up looks like for those who do not live close by, if they live far away from where they got their radiation, and if they cannot come back for routine follow-up, especially those with side effects needing management?
Yeah, it's like conducting like a video visit versus an in-person visit, I think is the question, right?
Yep, I think so.
So yeah, a lot of our 2-week follow visits will do a video visit just because we do get patients from up north, or right now a lot of our patients in the LA fires have been displaced and they've moved far away. So we'll do a video visit and then we'll just do a subjective interview. But after that, and that's also if the patient hasn't had any severe skin reaction where it's expected, it's red and they're not concerned. So we will do video visits for those. Video visits are okay for 6 months and so on. The only thing is we don't see the in-person and we won't do a breast exam, which is a big part of our department where we can actually see the texture change in that 6 month to 12-month after effect from radiation. I'll go over that in a little more where we see the radiation fibrosis develop around 6 months. So it's hard. Obviously, we would do it and take like a subjective interview. We prefer not to. And sometimes these patients will end up resuming care at their local medical oncology and resume care, and that medical oncologist will do the breast exam and continue their endocrine therapy and so on. But so it's hard. Obviously, we want to see the patients and continue monitoring their side effects, but it's hard to gauge that radiation fibrosis on a video visit and not do an actual breast exam.
And then just to add to that, if there is no video visit available, if the patient doesn't have that equipment, then sometimes we will ask for photos to be sent so that we can at least try to evaluate in that way. So I think something visual is helpful. Okay, so I will launch the poll and then we'll answer the next two questions.
Our next Zoom poll question is, who is at higher risk for side effects? And I'm sorry, move this over a little quick. Is it a slender woman receiving 50 grays and 25 fractions to the whole breast? Is it B, an obese woman receiving 40 grays and 15 fractions to the whole breast? C, an average woman receiving 30 gray and 5 fractions to the breast? Or is D, the risk of side effects the same across these scenarios? That is correct. Yes, B. Oops. Yes, B. An obese woman receiving 40 grays and 15 fractions to that whole breast will have higher risk of side effects. And that's primarily due to the skin on skin fracture, or skin on skin exposure to the extra folds, the friction in the underarm, all those. That's why we give those supplements on the pads and preventing this. And for some of these patients too, who are larger breasted, we would consider doing that prone treatment where the patient is facing down. That way only the breast is targeted versus like in any, especially avoiding any organs. But it tends to work a little better for the obese patients to be, and larger breasts to be prone. But this is the most common patient to have a side effect.
So I'm going to insert two more questions in here. So the other question we had is, what advice do we give to a patient experiencing radiotherapy fatigue?
So it's temporary and it's gradual. So usually that will come in week 2, week 3. And a lot of times the patients, if they have a short course, they'll continue with that at home. And so it's temporary. This is when the cells are regenerating. Radiation has done its job. It's killed the good and the bad cells, and now the good cells are regenerating. And it takes a lot of energy from the body to recreate these cells. So it's temporary. We advise them to, from the beginning to end those activity, daily living, we want them to continue doing their exercises. We want them to go to work, go to school. For the most part, those patients, we have patients that run to treatment and run back because that's part of their routine. And they do the best. They rarely feel any fatigue. So that's why we really push for it based on the tolerance, obviously, of the patient. And there's restrictions to age and all that. But it is temporary. It will subside just as it started. After radiation's done, it takes a couple weeks, may take a little longer for other people. And the main thing is you can rest, do what your body's requesting. So if you're tired, then take a nap. You definitely hydrate, don't skip meals. And just know it will subside, but it'll take its course. So it's a very common side effect too.
Yep, I think that's one of the guaranteed side effects of radiation, unfortunately. And we will often recommend patients to be more active if they can, because staying active helps combat that fatigue better than if they are doing nothing, sitting at home all day. So the other question is, are patients with left breast cancer on radiation therapy at a higher risk of toxicity or complications than those with right breast cancer on radiation therapy?
Not, doctor, you might have more study background on that. Sorry, my thing just subsided. Sorry.
So I would say from the skin side effect perspective, no. The main difference with the left versus the right is that the heart is leaning more towards the left. And so if you don't take special precautions, such as what we call breath hold, where we have the patients hold their breath for about 20, 30 seconds at a time to move the heart out of the way. If you don't do that, then the heart could get more radiation dose on the left versus on the right. And so that is something to keep in mind for patients getting radiation to the left side. They should be hopefully having some type of technique to protect the heart, move it out of the way. And I guess one more question that just came in. Can radiation therapy on the breast have an effect on the heart? So it can. I think we're still learning a lot about just how much radiation does the heart need to get. I think some older studies suggest even 1 unit of radiation can increase your risk of heart damage by to 7% increased risk of heart damage relative. So I think the data is still unsure. We know that radiation can damage the heart, so we try to avoid it the best that we can during the radiation planning process. Okay, I think that's the last question. Thank you.
Okay, so I think that was that. So I'm trying to remember okay. So on that note, we'll talk about just the topical creams that we use for common radiation dermatitis and moist desquamation. For radiation dermatitis, there's that common rash, itchy appearance that patients will complain, especially in that parasternal site. The first line that we use is over-the-counter cortisone, and just to help with those symptoms. And a lot of times, just over-the-counter cortisone is sufficient. And if not, we will use a prescription such as mometasone or triamcinolone, and we'll prescribe that. But regardless of either one, we like to use it towards the end of treatment. If it's really like in that first week and they had 5 weeks course, we'll encourage them to moisturize. Sometimes it is the radiation that's causing that dryness that can cause itchiness. So towards the end is we add the cortisone, and if that's not effective, we'll do a prescription. But the important fact is when these patients do apply these creams, we ask them to apply it first to the site, let it set for about 15 minutes, let it absorb, do its job, and then apply moisturizer on top. You want to create that sealant over it to help moisturize, because these creams are great with itchy, the redness, it will help, but it will dry them excessively. And so as a preventative measure, we tell them to definitely apply their moisturizer on top, and that can be the calendula or something thicker like Aquaphor, but that's a big fact to definitely relay to the patient to continue moisturizing when they've begun the steroids. For moist desquamation, that was that grade 2 that we saw on the scale, and that's when definitely there's been skin break, and there can be a little bit of the oozing of the skin, and that's just our defense mechanism trying to send all the cells and help create a barrier since we've burned off that first layer. People will complain of burning and pain to that site. And then our go-to in our department is Silvadene, which is a sulfa-based antibiotic that we use and it's used for burns too, and it's pretty soothing. The patients feel relief when they apply it. And obviously, if there's a sulfa allergy, we'll do something to us like a triple antibiotic, a neosporin ointment that can help the skin heal a little better and also obviously prevent infection since now the skin is open and there's a area for bacteria to come in the side. So those are the common things that we use in our clinic to help with the itchiness, the redness, or the moist desquamation. And then just to take note, when we do put them on Silvadene, it's usually about a week. And that's, I'm sorry, that same goes for the steroid. We don't use it for long periods. We don't want to apply steroid for usually longer than a week to 10 days. And same goes for the Silvadene. The Silvadene does its job. It's good for wet burns. The goal is to dry it up and heal it up. Once it does that, it'll continue drying and healing the skin so then you can have a reverse effect. Then they'll have a severe dry desquamation. So that's why these are short course treatments. And eventually, once they're done with that 7 to 10-day course, we want them to go back to their moisturizer because this is only temporary. Again, with radiation, symptoms are gradual, temporary, and they will resolve. It's not permanent, especially with these skin reactions. And then along with these two, we'll give them those pads that I showed earlier. That way the skin or the moisturizer, the creams will stay on and not wipe off on their clothing. And then again, we're still trying to avoid that friction from skin to skin. So managing the skin reaction, these are things that come up with our nursing staff, and we always want to just pass it on. We want to avoid adding insult to injury, which I was saying, avoiding that skin friction or trauma. So you don't want patients to be in the sun, having sun exposure, especially in that if they're having a really bad rash, you don't want them out in the sun with a low cut shirt. Shaving, we encourage obviously normal activities of daily living, but towards the end of treatment, if that underarm is really if it's broken down in skin and really raw, then we advise them to avoid shaving. Anything that's really tight, like in a really tight bra, then that's something that we can offer, giving them our surgical sports bra where they can use and with the pad in addition to help give them that barrier. Scrubbing. Sometimes patients will see the skin sloughing off and they'll want to do like a loofah or a scrub, like those salt-based scrubs, and we advise them nothing too irritant. You don't want to, we said, avoid any insult to this area that's already been traumatized. And this is the basic principle I was saying with the creams. When it's dry, you want to add moisture. But when it's moist, you want to dry it out. That's the theme we have. So if it's dry, add Aquaphor, get it nice and moisturized because you will peel and you'll just get new skin. But if it's moist, then we want to dry it out. And that's when we add the Silvadene to get that skin under control. Reassurance goes a long way with these patients. These symptoms we see day to day. We know what's normal. We know this will go away, but they don't. We have to remain calm and reassure them that this is just part of the course. It will subside, it will fade, and it's only temporary. And we'll help them along the way. We see them, we're there every day. Some of these patients we'll see every day because all they need is that 5 minutes to let them know this is part of the course. It will resolve shortly and we'll get them through it. For the nursing staff, we want them to inform MD&P of more severe skin reaction to allow our attendings to do an intervention. Sometimes my attending will give a patient a break. If it's so severe where the site is very open and wet and desquamated, our attending will decide maybe to give a patient a Friday off. That way they'll have 3 days off, let the skin heal, have the patient be a little more at comfort. Therefore, on Monday, when we check in on them, a lot of times the skin has settled down and it won't be so aggravated and raw, and then we can resume. Another thing is that what they'll do is transition to boost or remove the bolus. Since if there's a whole breast treatment, obviously the whole site is being radiated. And if there's a site that's involved and is really desquamated, our attending can switch to the boost. And usually the boost is very localized to the lumpectomy site. And that way, the remaining of the chest will be at rest, basically. Only that site is being treated. And we can, if we're like on treatment 10, we'll go towards the end. We'll just resume the boost treatment. We'll start the boost treatments And then we'll complete that. And then that way the breast hasn't been treated. And usually you can just resume going back to your routine radiation treatment and kind of finish in a reverse way. And also you can remove the bolus. That was that silicone pad that they apply over the patient when they're trying to really treat the skin, like in the inflammatory breast cancers. If you remove the bolus, then the radiation won't be so targeted to the skin. That way, we're not going to be aggravating the skin even more during treatment. So that's our two options that the attendings will make that decision in order to give the patient a little bit of a break, but continue along with radiation as well and not stopping completely. And then topicals, if there's things we can do like adding that Silvadene to help heal along the way, or that steroid to help with the discomfort and the itchy and that rashy appearance. Tell the patients what not to expect. A lot of patients are coming from chemotherapy and they feel this is just a part two of those symptoms. So they're going to be sick, nauseous, vomiting. They're going to lose their hair during radiation. Or are they going to be radioactive? They feel like once they get radiated, they can't go home to their grandchildren or be around family members. So these are common fears that we hear about it too. And no, usually with radiation, the main thing that we were saying earlier is fatigue. That's a lot of times fatigue can trigger things where people, if they have headaches, they might get now migraines because they're so tired and might trigger an imbalance. Nausea, we're not treating the breast, the stomach, we're not treating the brain. So those sides usually are either out of the fields or are not common side effects with nausea. But again, fatigue might trigger this on patients who have been going through a lot. They're going through anxiety, they're stressed. A lot of our patients have lost their homes during the fires. So all these things can just accumulate for the patient. And some of these symptoms do occur, but they're not directly related to radiation treatment. And hair loss, again, we're not treating the brain or the head, so that area is out of the field, but they will, a lot of times, will have hair loss at the underarm where the lymph nodes are treated or the tail of the breast touches that underarm. So sometimes you'll see like a fine break of where there's no hair in the underarm and they've lost that, but the above side where it's been out of the field, they have a little hair. So that there is a little hair loss there. And no, they're not radioactive. Once the radiation treatment is given, it enters and exits, they're not walking out active with any side effect from that, and their family members and all of us are not at risk for any exposure there. And we're talking just about fatigue. We want them to continue and being active if they're exercising, usually on a daily basis. Continue as tolerated. It's the best way to beat it, because as soon as you give into it, I feel those symptoms just really increase. So we'll go to our next Zoom poll question. True or false statement? Oops, let me get over a little bit, sorry. Skin moisturizing early in radiation treatment can lead to more breast skin breakdown. Sorry. True or false? Okay. So yes, false is correct. It is untrue. We want them to start moisturizing early in treatment to prevent any skin breakdown. Just like if you've ever been out in the sun and you get really bad sun exposure and you get sunburn and say you don't do anything, it would be more traumatizing and more achy, and you'd probably definitely have more side effects from that. So that's the perspective. We want to keep that skin preserved and moisturized throughout treatment, because even though you're not seeing any side effects at that first week, where they usually begin week 2, week 3, the effect has been made and the skin cells have been already damaged. So we need to keep that skin moisturized. That's why with the shorter course treatments, we ask them on that day 5 when they're done, please continue moisturizing the next 2 weeks, as the symptoms might creep up and they might show up a little later. But very important to continue early throughout treatment and a couple weeks after to maintain the integrity of that skin. Okay, so inform and reassurance of the patients goes on to and lead from our last slide. And sorry, I'm gonna move this over, locks me. All right, so the skin reaction, just inform the patient that it might look pink, it might look a little red, it has that sun reaction effect. It might feel burny, a little achy, sometimes itchy, like those pictures we had seen. Emphasize that these symptoms are very gradual, predictable, and only temporary. They're not going to be permanent. Usually the sequence is that the breast will get red and then tan and then fade away. There might be some possible texture changes where the breast becomes a little thicker, firmer, it feels harder, especially after radiation treatment. And I'll go in a little more detail in my follow-up part, or where those symptoms can be expected, especially around the 6 months. Who do I expect to have a more severe skin reaction? This goes back again to those larger breast sizes that have more exposure to the radiation, and especially if they're pendulous and really big, where we can do that prone position for that radiation treatment. Darker skin tends to have a little more reacted to the radiation. It picks up a little more of that energy and can have a little bit of a brisker reaction. The longer courses versus that short 5-day course. Post mastectomy, this is related to that question from earlier, especially if we use that bolus effect on the skin, they tend to have a little bit of a brisker reaction to those mastectomy patients. Implants and the expander reconstruction, sometimes during treatment, we'll see the expander rotate a little bit in the breast. Sometimes they'll flip, and we can see this on imaging. And patients will obviously feel something is wrong, that the expander pop, or they'll have the worst fears. And it's good to reassure them that this is something, it will definitely rotate in its little pocket there, and it's common. Asymmetry. Sometimes during treatment, there's a little bit of asymmetry to the breast. Sometimes, and this is mostly seen and is more prominent in that 6 month to year follow-up that I'll talk about, but it is common to see one breast a little higher than the other, primarily the site that's being radiated. And that tightening effect to that site that's being radiated, it will have, because of radiation, the skin will harden a little bit. A lot of times it's really tight and dry after radiation. So it's very important to continue moisturizing in those weeks and those months after, leading up to the exchange of the expander, because with radiation, after around that peak effect in 6 months, you'll have that tightening effect to the underarm, the breast from radiation. So it's common to have those tightenings. And again, I'll go over a little more of this in my follow-up part. And lymphedema, if the patient has had lymph node dissection to the site that's being treated, sometimes there is swelling. Very uncommon to have lymphedema to the patients that have had only a couple lymph nodes removed. If they've had obviously 20, 15, 20, then they have a little more of a swelling to that site, to that arm. Okay, and then the activity of daily life restrictions. We don't, like we were saying, we want them to continue their baseline. It is okay to perform all the following that we'll talk about. The physical therapy, a lot of these patients are in therapy to keep that extremity fluid and not tight. We want them to continue exercising. The shaving part, obviously, at the beginning is okay, but if they're getting closer to the end of treatment and that skin is raw, we want them to hold off. Same with deodorant use. If they're totally fine during treatment, if they're having that partial treatment and that area is not even in the area that's being treated, then it's okay. They can definitely continue with the normal morning application of the deodorant. And again, highly recommend all their activities of daily living. Restrictions throughout treatment. There's been recent studies showing that obviously moisturizing is okay to do right before treatment. The initial fear was that you're applying a layer where it can have the radiation pick up this as an additional layer and give you more radiation treatment and have a more brisker reaction. Then after studies have shown, it's really if you're applying more than 3 millimeters of lotion, or like you're really lathering on something thick like Aquaphor, then that's when the beam can pick up this barrier and feel like there's something thicker and penetrate and give more of a brisker reaction to, or more higher dose of radiation to that site. But if you're applying like something very thin, like calendula, and it gets absorbed, that should be fine. We don't want patients to jumping in jacuzzis, anything hot, or even like a pool, especially if they have those open wounds. Anything harsh on the skin we want to avoid during treatment. And again, any prolonged sun exposure, you don't want them tanning out in the summer in a really bikini where all this is exposed and it's just more trauma to the site that's already been having trauma during treatment. So diet restrictions during radiation treatment. There's no real restriction except the two vitamins that we advise in our clinic to hold off, and that's the C and E. We just advise them to hold off on any antioxidants during treatment. And this is an ongoing study of the antioxidants that we consume with these two vitamins C and E. The radiation treatment produces these radicals that help kill the cancer. And what the antioxidants do is they'll basically neutralize them to get rid of them. And then that way it's like a contra effect from radiation and these antioxidants. So we advise them to hold off. Obviously, they can have their orange juice, some berries, that's okay. We just want them to hold off on really high doses of the over-the-counter vitamins. We have 1,000 milligrams of vitamin C. That's something we would want them to hold during treatment. So in this part, this is where my role begins in our department, where I see the patients in follow-up visits. And obviously the nurses staff when they bring the patients in. And it's just that visual, that verbal assessment. I'll go into detail for all of these. Imaging surveillance that I start them on, any multidisciplinary visits. Are they meeting with medical oncology, surgery, any cosmetic concerns? Is there physical therapy on board? Are they attending? Do they need a referral? Is there a psychosocial support that is needed along the way? And of course, just always having that reassurance with every visit. So in follow-up care, I want the patient and the nurses also to be aware of what's common, what's normal with radiation. And there can be the hyperpigmentation or the hypo, where you see at the top where there's one picture at 2 months or after 2 months after radiation, where they still have that darkening effect to that chest wall. And then about a year later, the tanning is almost resolved. And then they can also have the opposite effect where they've lost the pigmentation to that site that's been radiated. And in our follow-up visits, I do a 2-week follow-up visit once they complete treatment. And that visit is usually in person, but like some people do live far. And then since we had just seen him and if there's no real skin reaction, we will do a video visit for those. It's okay. But when we have them come back at 6 months and then at 12 months, we do prefer an in-person visit to do an actual exam and assess the texture of the chest or the breast and see if there is any aftermath from the radiation effect. So in the follow-up visits, one of the main things I assess breast pain. Is there any side effect that they're feeling? Is there any still residual, whether it's at the 2-week visit, if there's still obviously any skin desquamation going on. But at the 6-month visit, I assess if there's breast pain from radiation fibrosis, which is seen really at that 6-month visit. And I'll go over also metastatic surveys. So is the patient experiencing any headaches? Is there like coughing, any shortness of breath, any bone pain and it's not related to radiation, but is there a metastatic effect on the cancer? Imaging surveillance. So I will get them started on their imaging. I basically restart them in their mammogram screening. So if they've left off at a certain month, I resume them back on that month. And this is obviously pending if they still have both native breasts. If they've had one mastectomy, then I just resume the other breast. Do they qualify for our UCLA protocol high-risk screening? So we get these patients they have genetics involved, if they have recurrence, if they've been diagnosed under the age of 50. Things like this are ways to get them approved for a high-risk screening and approved by insurance purposes. And we would get them started with mammogram wherever they left off. And then 6 months after that, we would do MRI screening. So basically every 6 months they have some type of screening, but it'd basically be one mammogram, one breast MRI every year. But again, that's a specific protocol that we use for specific patients. Aside of that, it is routine yearly mammogram screening for the patients once they're done with treatment. I believe the routine screening for patients without breast cancer is now every 2 years. So we would resume on a yearly basis now with the breast cancer history. There's also PET scans and CT scans that are done, but in our department, we usually let medical oncology take the course on that. For the most part, there'll be surveillance under medical oncology once they're done with us. We are an additional set of eyes to these patients based on the medical oncology assessment that sometimes they're on like blood work, tumor markers, they're monitoring the DNA, like breast cancer DNA, and sometimes these markers will rise, and the PET scan is prompted based on also on patient symptom or the doctor's assessment. So on those scans, we usually let medical oncology take the role on that. And then are they following up multidisciplinary? Do they have medical oncology visits already scheduled? For the most part, when they finish treatment with us, about 2 to 4 weeks after a completion with us, they will start their endocrine therapy. And this is for patients who've had breast cancer, who are estrogen, progesterone positive, and we'll get them started on the endocrine therapy to suppress the estrogen that way. It prevents cancer for probably like around 5 years. Sometimes they'll do 10 years. And it prevents breast cancer either to the contralateral side or systemically. And this is obviously not something for patients who are triple negative breast cancer, where their cancers were not estrogen receptive. For those patients that are triple negative breast cancer, some of them are on immunotherapy as either along with radiation treatment or post with treatment. And then sometimes these patients will also follow up with breast surgery. And sometimes our breast surgery department will manage imaging, and they're also monitoring the seromas and hematomas that some of these patients already have when they come during our treatment. So there's a couple roles involved in our department. Some patients will follow all three of us for the next 5 years. Every 6 months, they want that high surveillance on them. And then some patients will just do one of us and continue. But in our role, in our department, medical oncology is the main person to take the surveillance role, and will be extra set of eyes. And then there's the cosmetic concerns that definitely develop along the way. And this is what I was saying, around 6 to 8 months is the peak effect of radiation treatment. At that point, you're seeing the evolution of the skin contract. Sometimes you'll develop that retraction, like in that top or both pictures, you'll see their right breast has lifted a little bit. It creates that lift retraction versus the side that hasn't been radiated, it'll be lower. For the most part, plastic surgeons try to avoid touching the site that's been radiated, and will try to do a lift on the contralateral side just to create some form of symmetry. But for the most part, they'll try to wait at least 6 months to see where the skin and the breast is evolving. Some plastic surgeons will wait that full year and see what the new normal is. They say it's like a moving target if you do it a little too preliminary, and that way you're not getting the actual final outcome. So a lot of times they'll wait about a year. On the site that's been radiated, sometimes I've seen plastic surgeons like a year, maybe 2 years after, they'll do some fat transfer from the patient's belly, and then they'll inject it to that site, especially if there's volume loss to certain sites or like a Ripley effect from the implant. So that those are things that the plastic surgeon will consider. But this is common that we have this on patients who have had any type of the whole breast radiation treatment. Usually will have a little bit of symmetry change. Some patients have very minimal, like the small partial breast will really have nothing. It will have really great symmetry, but depending on the volume of the breast that's been removed during the lumpectomy, the type of radiation, some of them will have severe radiation fibrosis where the skin is really hard and dense and retracted. So that will cause a really big asymmetry, and patients obviously are unsatisfied with that. So around the 6 month follow visit is a good time to touch base with plastics and see what they recommend, and their expertise will definitely be relied on in this part. And then physical therapy, a lot of times this is started by surgery right after their procedure, but you can see if they've had increased lymph nodes dissected, you'll start seeing swelling. And some patients will have a lot, about 20 lymph nodes, and you'll see no swelling. So it really does vary. but it's something to be aware of in all our follow-up visits and keep track of. Physical therapy will do their own assessment, their own measurement. They'll prescribe certain sleeves or certain garments for the bra that encourages the lymphatic draining. So the physical therapy is a very important role in especially in radiation, to get started if we see it in those weeks when they're in treatment. Range of motion restriction, especially if they've had that lymph node dissection and now we're adding radiation to that, it can cause a lot of pain and tightening and limitation. So you'll see that restriction. Sometimes you'll feel the cording of the lymph node dissection along the underarm, extending up to the arm. So that's something that the therapist will really work at and need at and help with the tightening and that restriction. But it's really important to get this started. The sooner the better. You don't want patients coming in with swollen arm like stage 4, or having that restriction like the bottom pictures, where I've had patients say they noticed it when they went to close the trunk of the car. They weren't able to lift because it is so tight. And a lot of times you see this in elderly patients because they're not exercising, a lot of them. They're more at home doing small things and they don't really use that full range of motion. So when they come to us, we can see it. And again, this is 6 months later. So very important to get this started, especially after surgery. A lot of those patients should just automatically be referred because that area has already been traumatized. So we play a big role in this referral too.
And Daniela, on this slide, I just wanted to point out, as nurses, you may get lots of questions from patients about lots of worries and concerns that they have. And they may know other breast cancer survivors who have really bad lymphedema, and they might ask you like, hey, am I going to get this? One really good clue to be able to tell as a nurse, is my patient going to get lymphedema or not, is look at the surgery that they got. Did they get an axillary lymph node dissection? If they got an axillary lymph node dissection, then they're at a higher risk of lymphedema. If they didn't get any axillary lymph node dissection, they're at a pretty low risk. And then the second thing is look at the radiation treatment that they're going to get. See if the doctor wrote that in their notes. If the radiation treatment is going to treat the supraclavicular field and the regional lymph nodes, that's also going to put them at a higher risk of lymphedema compared to if you're just treating the whole breast. If you had a patient who didn't get any axillary lymph node dissection and you're not treating the regional nodes, their risk of any severe lymphedema is very little, like almost 0%.
I think what Dr. Lee is saying also, patients with DCIS very rarely get their lymph node sampled. And a lot of times they'll ask us, am I at risk? And if they didn't have their lymph node sampled and we're not targeting their supraclavicular nodes, then their risk is basically, I would say, 0 to 0 from radiation and surgery.
All right, thank you.
One related question, which I think has more or less been addressed by you, but just to clarify. So the question was, how can nurses help manage patients with lymphedema of the arms? And I think the take-home point that I see is that nurses may help detect if patients are at risk of lymphedema or if they have early signs of lymphedema, and can assist in making sure the patients see physical therapy and get the resources that they need to try to help prevent or treat lymphedema.
Yes, yeah. And a lot of things that we see is very common where they won't even have the fear of lymphedema. They're not aware, they forget. And they'll just, when we say head to toe assessment, is there anything that's been bothering you? And that's where we're doing like the metastatic assessment. But then they'll say, oh, I stopped wearing my wedding ring. I can't wear it anymore. Or my watch doesn't fit. And they're like, it's fine. I don't mind it. But then you'll see the interface or the anterior side of the wrist, and you can see the veins are started to fade. Same in the AC part where the veins are no longer present versus the other arm. So it's a good comparison to see from arm to arm. But those are good cues from the patient where you know they have had some swelling, and then you can, like you said, refer to physical therapy, and they'll do their, I'm sorry, this is they'll do their proper measurement and get them started on a sleeve or like that breast lymphatic garment that they put on the breast to assist. So yeah, it's good to listen to the cues of these patients that even they may not have that fear. Okay, any other questions?
So I see another one asked, Melvis asked, how does radiation therapy cause lymphedema? And so I think Dr. Ben addressed that in a great way. So to help summarize that, radiation can cause lymphedema if you're irradiating the lymph node regions where the lymph nodes are. That can increase the risk of lymphedema on top of whatever risk the surgery has already provided. So if they're getting that full lymph node dissection where they're removing multiple lymph nodes, then that can make the risk of lymphedema anywhere from 20% or so, 25%. And then if you add the radiation to that same area, the lymph node regions, that can increase it by another 5 to 10%. So the risk could be as high as 30% in those people. And so those are the high risk patients.
Then in the follow-up care, we have psychosocial support. I know there's a whole different department that will be touching base on this, so I won't spend too much time, but it is commonly seen towards the end of treatment where depression, anxiety, and trouble of coping this can hit them. It's a really fast roller coaster for them as soon as they get diagnosed. A lot of them are obviously caught off guard. They went in for their mammogram screening and now they have a new lump and now they have, or they palpate something and they'll see their doctors, they get diagnosed, they have surgery, they have chemo, and then they get to us. And then on the final day of treatment or in my 2-week follow-up visit, I'll just find them sobbing in the room and they're just like, I don't know what to do next. Like, now who's going to be watching me? The surveillance is over. Because at least in that part where they had someone along them with them, the medical oncology or us or surgery guiding them what to do, and they knew they were doing something to get rid of the cancer, but now that it's all done, it'll hit them and they feel lost, they feel alone is what they say. So in our department, we have a great support system. It's the Sims Man department where it's focused for our cancer patients and their family. We have therapists, psychologists, psychiatrists that are involved, and they get therapies. They obviously get assessed and sessions, and obviously, if needed, any other additional resources. But this is a very common thing that we see, especially in our department towards the end of treatment, where they actually have the time now to think and it hits them like, and then the fear of this coming back is a really strong symptom that they have. So this is very important to address right away. We have so many resources in our department, and this has been one of our strongest ones that we should definitely, in any hospital, in any facility, something that we can assess on a daily basis. And in every follow-up visit with these patients, it can happen right at the end or 6 months or a year later, etc. So always to keep in the back of our mind. And then the follow-up reassurance. Now that they've completed treatment, we have to really give them the credit that they've graduated from treatment. We do the ringing of the bell at our department where they feel like they've accomplished. We give them a certificate that we all sign, and it's something really to celebrate them and reassure them that they've done something amazing, like they've put their life on hold for that month or whatever it was, and they've really completed something. They've completed an important chapter in this whole roller coaster of emotions. So it's important to really address that. We want them to know they're going to have continued surveillance between all their providers. We are all there. We have this MyChart system in our hospital where they can reach us on a quick text message, and then it comes to our company phone, and we're always accessible to these patients. So we want them always to feel like they're not alone. There's multiple resources. Like I said, we have our psychosocial department, we have physical therapy, we have our social worker, that if there's things that are, some patients don't have transportation to get to our treatment or our follow visits, that we can help in some way. So I would always advertise that there's always a resource within our department that you can always give that lending hand to these patients, because again, this is all normal to us. We do this every day, but they don't know. They're in such fear and they're in the cloud. So we literally have to give them that hope and that window to all these resources. And we are here for all the patients at all times. And I think this is our last poll question. Reassurance during radiation therapy is an important act to assist with which of the following? Is it A, OCD, B, depression, C, cosmetic outcome, or D, hot flashes? Okay, so yes, B is the correct answer. Depression is such an important symptom that the patients feel, and it's during radiation, just to reassure them. that this is part of the course, we are there to support them, and just that constant feedback to them will help them along the way, especially if they're prone to having that symptom and that diagnosis of depression. So it would definitely assist speaking to them and just giving that positive feedback throughout treatment. And I think that was it to that.